This program is brought to you by Emory University.
I want to introduce Paul Forfia, who just joined Emory as the Director of Pulmonary Hypertension, Right Heart Failure, and CTEF program. But before that, he's spent years at Temple University, where he actually built the whole CTEF program. Was a very successful CTEF, chronic thromboembolic pulmonary hypertension program that offers all kind of treatment. He had referrals from all over the country. He built a big name when it comes to combination of pulmonary hypertension, chronic thromboembolic pulmonary hypertension, right heart failure. He's had many publications in that field, is an expert at exercise physiology, and he will give us a grand round this morning. We're very happy to have him here as we build our own program too. Paul, thank you for giving this talk.
So I was asked to welcome everybody. I was asked to give grand rounds, not long after arrival, and this was the date that we came across. So here we go. For those of you who I have not met, I'm sure our paths will cross in the relatively near future. So I decided to give a little bit more of a broad discussion on pulmonary hypertension, entitled Pulmonary Hypertension, a Rare Disease. It depends on how you think about it. And I think what I'll do is I'm going to walk you through kind of a lot of the concepts related to pulmonary hypertension and impress upon you that pulmonary hypertension is not as rare as people think. It just depends on how you consider it. And so the one thing I know for sure is that pulmonary hypertension programs can have a ripple effect within a healthcare organization, a region, and even semi-nationally and nationally. High functioning PH programs unlock additional high-end care. So for example, heart transplant, lung transplant, renal and liver transplant, valve surgery, structural heart programs. Without a high functioning pulmonary hypertension program, many patients don't actually access these types of care. Oh, patient's PVR is theoretically too high, they can't have a heart transplant, or there's an extensive degree of pulmonary hypertension, at least theoretical barriers to renal and liver transplant. There's very important considerations related to PH in structural heart programs. We just had a meeting last week about the importance of vetting through the physiology of underlying tricuspid regurgitation as a key portal of entry to safe, isolated tricuspid valve repair and replacement. And then, of course, we'll talk about CTEF toward the end here. To be your best at diagnostics and treatment of pulmonary hypertension of any kind, there's two key concepts you have to follow. One is to apply and adhere to physiologic principles. And what I mean by that is apply and adhere to the physiologic principles over patterns and categories or what someone else told you, okay? I'm going to go over this in some detail. And of course, listen to and carefully assess your patients. The patient will typically tell and show you the diagnosis and the treatment if you know how to listen. One of my favorite quotes in medicine is from Sir William Osler. And what he said is that to study medicine without reading books is like going to sea without charts, but to study medicine without dealing with patients is like you have not gone to sea at all. And it really is through the integration of clinical and imaging and hemodynamic information that the patients themselves are our greatest teachers, again, if you are paying attention. So is PH rare? This is what I've been told most of my career is, you'll never build a pulmonary hypertension program at Penn. It's way too rare. Paul, you'll never be able to build a CTEF program in Philadelphia because UC San Diego has a program and there isn't a need for another CTEF program. At almost every major node of my career, I've been told that I can't do something that we ultimately went on to do. Part of the reason is people cite how rare the disease is. But it depends on how you approach pulmonary hypertension philosophically. Are you exclusive in the way you approach pH, or are you inclusive in the way you approach it? So we all know the World Symposia groupings: Group 1, PAH; 2, left heart disease; 3, chronic respiratory diseases; 4 is obstruction, including thromboembolic disease; and Group 5 is everything else. Kind of the two prototype conditions in the World Symposia groupings are Group 1 and Group 4, PAH, Group 1, and thromboembolic pulmonary hypertension within Group 4. If you look at this kind of 10,000-foot view of a stream or a river cutting through a forest, this is the detail you get. But if you're mountain biking within the forest, like I've done many times with my sons, it may look something like this. And this is in a lot of ways the way that I view pulmonary hypertension is, from a non-expert vantage point, or even from some experts' vantage point, pulmonary hypertension is fairly categorical in its nature. And it's very easy to fit pulmonary hypertension into these groups. But the more patients I've seen and the more I've learned over the years, the more I've appreciated all of the nuances of pulmonary hypertension and how oftentimes patients don't fit neatly into one category or another, which then has forced me to go back to my physiology training from graduate school and reduce the condition back to its physiologic roots. What is pH in actuality? Well, mean pulmonary pressure is nothing more than the product of cardiac output multiplied by pulmonary vascular resistance and the addition of downstream left atrial pressure. And so both of these patients, apical four-chamber echoes, are associated with the same pulmonary pressure, 70/30 in both cases, both patients of mine over the years. The patient on the left, I can assure you, has a significant form of pulmonary hypertension. And the patient on the right, I can assure you, does not. And so this is pH for sure on the left. And come on, give me a break. This is not pulmonary hypertension on the right. They may have pulmonary hypertension by strict hemodynamic criteria, but they do not have what I call the pulmonary hypertension syndrome, which is what I'm about to explain to you. So clinical classification is a diagnostic assignment, and in some, the diagnostic assignment and the physiologic understanding run fairly close. In many others, this is not the case. And so understanding and characterizing the pathophysiology of pH should always come before the assignment. And that's not what I have seen in my career. There's a tendency to want to categorize patients from the get-go. And I think there should almost be a rule in pulmonary hypertension where you have to count to 50 or something before you're done categorizing the patient and consider all of the aspects of a case. And try not to oversimplify it initially and just jam it into a category, but take that time, look over the physiologic aspects of the case, integrate it with the clinical findings, because ultimately what we're asked to do is help patients. And I think this is the best approach. And so years ago, I started teaching about this thing that I call the pulmonary hypertension syndrome. And so what is it to me? It's a condition of functional or exercise impairment related to, one, a diseased pulmonary vascular bed. Okay, so that's increased afterload, right? That does not mean increased pressure. That means increased afterload. I'm going to come back to that. There must then be a mismatch between intrinsic RV systolic function and afterload, leading to RVPA uncoupling. Thus, the RV and the right heart cannot overcome the afterload imposed by the pulmonary vascular disease process. The way I teach it to learners is the pH syndrome has 4 criteria, and you have to have all 4. One, you have to have known or suspected pulmonary hypertension. You have to have objective evidence of high afterload. We're going to spend some time on this. It's a little trickier than people think. You have to have right heart dysfunction. And you have to have a clinical presentation that matches or fits with items 1, 2, and 3. So you say, well, that's pretty straightforward, but then if you don't understand what afterload is, then you're already going to be behind the 8 ball. The way that we're taught in medical school is that high pulmonary artery pressure is afterload on the right heart, and that high mean aortic or systemic arterial pressure is afterload on the left heart. Although from a strict hemodynamic perspective, that is completely incorrect, in that the actual definition of afterload is the force or forces that oppose ventricular function, that is at the level of the heart. At the level of blood flow, afterload is the force or forces that oppose blood flow, okay? And so pressure does not oppose blood flow, and pressure does not actually oppose ventricular function. Afterload is a composite measure comprised of resistance and stiffness, elastance, and the timing of reflected waves coming back from the peripheral circulation. So the actual most complete way to determine all 3 of these terms, resistance, elastance, or stiffness, and wave reflection, is through something called an input impedance spectra, where you use a pressure flow wire either in the proximal aorta or the proximal pulmonary artery. And you actually do a Fourier transform of that data across multiples of the fundamental frequency of your pressure flow relationship, and you develop a graph from the 0 harmonic, which is your mean term, resistance, that's shown all the way at the top left of the y-axis, all the way out to several multiples of the fundamental frequency, say like 12 hertz. And what this gives you is resistance, and that nadir at there where it says frequency at first minimum impedance, that's actually wave reflection. And then all the way out on the right is your average modulus after about your 4th or 5th harmonic, and that's impedance through characteristic impedance or large vessel stiffness. So why am I even showing you this? I'm actually showing you this predominantly to show you that we don't use this, right? Unless you trained with a biomedical engineer in fellowship or something, you would never have seen this, okay? And I don't think we'll ever see this in clinical medicine. And so I was very aware of that early in my training and was trying to consider kind of a much, much simpler practical way to get at resistance and stiffness and wave reflection in a clinically practical way. And if you look back in the literature into the 50s and 60s, from people like Milner or Nichols or Rourke, or David Cass, my mentor, they were working on these things way back in animal models. And so what existed in clinical medicine was the pulsed wave Doppler in the RV outflow tract. And what the Japanese paper in the early 80s said was that if you have this notching pattern, which is most clearly depicted all the way on the right, then you have, quote, pulmonary hypertension. But the authors of that paper themselves indicated that half the people in the data set that had pulmonary hypertension were not notched. And they actually correctly surmised at the end of the paper that maybe it was not pressure itself that was causing the notching pattern. And so we kind of picked up on that. I started really looking at this in about 2005 or 6. And so if you look all the way to the left, those are 2 examples of a no notch pattern. Then we have the late notch pattern in the middle, and the mid-stop notch pattern all the way to the right. And if you go from left to right, the pulmonary vascular physiology goes from normal to the most severely diseased. And this is a quick visual window into a composite of resistance and stiffness and wave reflection in a single measure. And I'm going to come back to that in a little while, but this relates your mid-systolic notch all the way on the right is an indicator that there's high resistance, the pulmonary circulation is stiff, and reflected pressure waves are arriving back to the heart while the pulmonic valve is still open. And that's what causes a temporary reversal of flow that digs out this notch in mid-systole like this. This is an instantaneous piece of information that tells you that the PVR is greater than equal to 7 Woods units. This was actually in our original paper, was 96% specific for a PVR of greater than 6 Woods units. So who ultimately decides if the PH syndrome is severe? Well, it's really the right heart that will tell you. If you have 2 patients here with pulmonary hypertension, the person on the left has a much greater degree of recoupling of the RV to pulmonary circulation as compared to the patient on the right, who's completely therapy naive. I met this woman in the emergency room many years ago at the beginning of my career. So why does any of this stuff matter? Well, I would argue that it matters more now than ever. If you look at the 2022 ESC/ERS guidelines, well, heck, I mean, they've dropped the mean pulmonary pressure cutoff to define pH at 20, and the PVR, shockingly, has been dropped to 2 as the upper limit of normal. So what this does is it greatly decreases the specificity of the pulmonary hypertension definition guidelines. It does not account for things like age, BMI, the person's blood pressure at the time the pulmonary pressure is measured. And so, in my strong opinion, the guidelines have changed for the worse, in that they have gotten so lax and so broad and inclusive that you don't really know what you're actually capturing anymore. And so you need to rely on more physiologic guidelines and more other context clues. You cannot go off the right heart catheterization itself. It's just not specific enough, particularly at this level of cutoffs. So the physiologic approach is needed now more than ever. We'll first just go over group 1 and group 2 for a little bit, and then I'm going to go through the other groups and show you examples of things I've done in my own career along these lines. We all know that one of the fundamental diagnostic approaches to pH is to separate pulmonary hypertension into pre versus post-capillary disease. This is very fundamental. Being fundamental doesn't mean it's that easy. And this is one of the most common places where a misstep can be made. And so I'll give you an example or two. So here, this is easy, right? So if the wedge is greater than 15, it's group 2 disease. So that's super great. So I have 2 cases for you. I have super easy case number 1 on the left, and I have super easy case number 2 on the right. So let's start on the left. Patient's pulmonary pressure is 70/30 with a wedge of 18, right? So you say, well, that's no problem. That's group 2 pulmonary hypertension. Thank you very much. But of course, there's more information than is being shown. So just be careful. Well, this person's right atrial pressure is 21 and their wedge is 18, which means that their RAP to wedge pressure ratio is greater than 1. It's a very unusual, very high ratio for someone with, quote, left heart disease PH, that their right atrial pressure would be higher than their left atrial pressure. Keep that in mind. Let's keep going. Here's the hemodynamic waveforms with a symmetrical A and V wave. And like I said, the left atrial pressure by occlusion pressure, 18 millimeters of mercury. Okay. It's notable that there is no significant or dominant V wave here. And again, the RAP is higher than the LAP. Let's look at the rest of the information. The cardiac output's 3, the index is 1.6, and the PVR is 8. And the PVR to SVR ratio is 45%. That is very, very high. Understanding that the physiologic ratio of PVR to SVR is anywhere between 10 and 15%. In my career, I have learned that a PVR to SVR ratio of less than 1/3 typically is relatively clinically insignificant, and greater than 1/3 is clinically significant. So this is really quite high. And then here's the person's echocardiogram. And you could spend a month trying to convince me this person has left heart disease PH, but I'm not going to believe a word of what you're saying, because this person has all the characteristics of a pulmonary vascular disease process. And the dominant pathophysiology here is a pulmonary vascular disease, high right heart afterload, RVPA uncoupling. And I can guarantee you this person is short of breath on exertion, and has all of the classic underpinnings of a PH syndrome. And so you could call this group 2 if you wanted. One, I'm not going to believe you. And secondly, I'm still going to treat the person's pulmonary vascular disease. Okay, super easy case number 2, 70/30, wedge is 18. Oh, by the way, you see the arrow there? That's just to indicate that when there's a lot of tension in the right heart, we'll often transmit partially across the interatrial septum, which is one of your explanations for why the left atrial pressure becomes elevated, is just the interdependence between a failing and under tension right heart and that pressure being transmitted across a very thin piece of tissue, the interatrial septum, in a heart that's bounded in total by the pericardial sac. So back to our case on the right, 70/30, wedge is 18, except this time the right atrial pressure is 7, and the RIP to wedge pressure ratio is less than half, which is more typical of left heart disease PH. Here's your actual hemodynamic waveforms. The A wave, a large V wave. In fact, the A wave's at 18 and the V wave is at 40. Now, this is actually a very different scenario, and this is creating a much more compelling story for a left heart disease process. Cardiac output is 6, index is 3, and then you say, well, the PVR is 4, and according to the ESC ERS guidelines, that's actually double the upper limit of normal. However, we can never rely on a single cutoff really for virtually anything, right? And if you look at the PVR to SVR ratio, it's actually only 21%, which is pretty underwhelming. Oh, and by the way, the person's blood pressure at the time the cath was performed was 190/95. And then if you look at their echo, it looks like this. And then you say, what are we actually dealing with here? And the answer is you're dealing with someone with hypertension, hypertensive heart disease, a stiff left heart. By the way, this woman did not have significant mitral regurgitation. It is not uncommon for large V waves to occur in the absence of mitral regurgitation when the left atrium is quite stiff. I would not treat this person for pulmonary hypertension with PH medicines as long as I lived. I would actually just treat them in the more expected fashion of blood pressure control if they needed diuretics, etc. There are times when the separation between right and left heart failure are easy, and sometimes it's a little trickier. So if someone had a dilated cardiomyopathy with an EF of 15%, this is not a diagnostic conundrum. This is fairly advanced stage left heart disease. 4+ MR with a normal EF and PH, also not a diagnostic conundrum. 3+ eccentric MR with an EF of 50%, also very unlikely this is a pulmonary vascular disease process. The predominant physiology is going to be driven by the dysfunctional mitral valve. By the way, that last case, if you needed to, this is a case where it's a very easy application of invasive cardiopulmonary exercise testing to show that the person pressurizes their left atrium at low workload during exercise. A very common referral over my career has been patients with a normal LVEF, some degree of PH on an echo. And what happens is this Venn diagram occurs somewhere between HFpEF and PAH, where patients are short of breath, their LVEF is relatively normal, and they have some element of pulmonary hypertension. And then how do you separate them? This actual referral pattern was the stimulus for a lot of research I did at the beginning of my career, where we were leveraging the transthoracic 2D Doppler examination to differentiate pre from post-capillary pH. And I'll quickly go over some of that stuff. Remember your three S's: size and systolic function and septal position, what I often refer to as squeeze, size, and smush. Squeeze, function, size, and smush is septal flattening. Look at your grade for diastolic function and the notch. Looking at your RV here on the left and the right, the RV-LV ratios are very obviously different between these two. It's very important to also understand that the shape of these right ventricles is also very fundamentally different. We published a paper several years ago actually showing that the shape is highly indicative of the pulmonary vascular resistance, which I'm going to show you in a second. And that's the paper I was referring to. And so if you look at the end systolic dimension at the base of the right ventricle and the end systolic dimension in the distal third of the right ventricle, the closer those two dimensions are to each other, the higher the PVR is. So imagine on the top left there that the RV end systolic dimension at the base is 5 centimeters, and at the distal third, it's 4.5 centimeters. That's very typical of a pulmonary vascular disease process like PAH or CTEPH. And the one in the top right, you can see that that right ventricle kind of cones down to a triangle like that. And that's actually very typical of a low PVR process. And so a lot of times you can tell if the PVR is high or low by an instantaneous look at the shape of the right ventricle. Systolic function, you can measure in many different ways, whether you use global measures like fractional area change, longitudinal measures like TAPSE, S prime, longitudinal strain. There's many ways to do this. What I always recommend is that at least 2 measures of RV systolic function be used. So maybe 1 longitudinal measure and 1 global measure. Like so, for example, you could use longitudinal strain and fractional area change, or you could use TAPSE and fractional area change. For what it's worth, the ASC guidelines indicate that a TAPSE more than 1.6 is normal. That's actually objectively wrong. The normal TAPSE in a normal healthy individual is 2.5 centimeters. And so 1.6 is actually moderate RV dysfunction in patients that have not had their pericardium opened, which is obviously overwhelmingly the largest percentage of our population. And when the LVEF is normal, a high pulmonary vascular resistance is by far the most common cause of RV dysfunction. Okay, that's one of the convenient truths about the right heart, is that almost every single explanation, not every, but almost every explanation for a dysfunctional right heart is explained by high afterload in clinical medicine. Septal position, we're looking for the presence or absence of systolic septal flattening. Echo textbooks will tell you that this is from what they call pressure overload. That is also not true. This is not a pressure phenomenon. This is a high afterload phenomenon that delays the time to RV peak contraction, creating mechanical dyssynchrony between the right and the left side of the heart. That was actually shown in a tagged MRI study by Anton van Noordegraaff's group many years ago. So this has nothing to do with pressure, and it has to do with resistance and the slowing of the time to RV peak contraction relative to the time to peak contraction of the LV. That offset creates dyssynchrony, which then allows the septum to be flaccid on the left ventricular side, halfway through systole for the RV, and then that causes the ducking over of the interventricular septum. I don't have to go over transmitral Doppler patterns with a group of cardiologists, but it's important to just remind you that the pattern on the right of this kind of E to A flipped pattern is very typical of a normal left atrial pressure in patients with a high PVR. And lastly, the notch, as we've talked about, pressure waves traveling away from the right side of the heart to this site of maximal wave reflection in the pulmonary circulation, which is usually around 30 to 35 centimeters from the pulmonic valve. And a percentage of the forward traveling wave will reflect or bounce back to the pressure wave generator, which is the right heart, right ventricle. And if that reflected pressure wave comes back while the pulmonic valve is open and the RV is still ejecting, it will instantaneously oppose flow, creating that notching pattern. So in order to have the notch, you have to have a high PVR, stiff pulmonary arteries, and pulmonary vascular disease. And so we had a paper a number of years ago where we said, look, just look at the left atrial size, the E to E prime, and the notch. And if you assign a point scoring system to these things, minus points in favor of left heart disease and +1 for right heart disease, what you see is that as you go from a negative to a positive echo score, the wedge pressure is going down, the transpulmonary gradient is going up, the PVR is rising. Guys, please pay attention to the bottom left graph, that there is no difference in mean pulmonary pressure from the -2 echo score to the +2 echo score, right? So this does not discriminate the presence of pH, it discriminates the origin of pH, which I think is much more useful in clinical medicine. We did the same thing, quote, virtually, a number of years ago, where we said, look, you don't even have to look at the echo itself, although looking at the primary echo images works better. But if someone was, say, did not know how to read an echo, you could actually look at clues from the echo report and assign a point scoring to that. And it performs qualitatively in a similar fashion, where the higher your virtual echo score, the more likely you have precapillary pH. The lower your virtual echo score, the more likely you have postcapillary pH. So what can we do with this information in group 1 disease? Well, I'll briefly just go over with you that risk stratification in PAH is classically defined as when a patient has PAH and they're on therapy and you're following them longitudinally in clinic, for example, that you look at their 6-minute walk distance, their functional class, and their BNP level. And the composite of those three things is principally what determines patients' risk. What's so interesting about that system is that it does not include any cardiac imaging whatsoever in the risk stratification. And 2 of the 3 parameters in the risk score, which is a person's walk distance and their functional class, are incredibly subjective and variable and determined by things like your age, lean body build, the presence or absence of musculoskeletal limitations. And then lastly, your BNP level can be dictated by your body mass index and your degree of adiposity. How many times have I seen a patient in florid heart failure with a normal BNP level, but they're morbidly obese, right? And so what we did in this paper is we took patients with PAH that were intermediate risk, and we looked at what their TAPSE was and the degree of their tricuspid regurgitation, and look at the survival difference within the same intermediate risk group. The yellow line are patients whose TAPSEs are greater than equal to 1.9 with mild TR or less, okay? And those patients had a very, very good 5-year survival rate. Whereas if you were intermediate risk and you had a lower TAPSE with more significant TR, your 5-year survival was terrible. It was well less than 50%. And so what we showed in the paper is that embedded within the intermediate risk group, as defined as functional class, walk, and BNP, that if you look at their echo for RV function and degree of tricuspid regurgitation, it actually indicates that some of the patients are low risk and some of the patients are high risk. And so this paper and a career long of experience will tell you that adding cardiac imaging into risk stratification is mandatory in order to get optimal understanding of a group 1 PAH patient's risk assessment. This is just showing you that if you follow TAPSE over time, it's a much more powerful predictor of survival than the baseline TAPSE value that is obtained when the patient is therapy naive. And this is a similar kind of approach for predicting survival in PAH, where, again, a composite of RV function and tricuspid regurgitation is the most powerful predictor of good survival, good TAPSE with low TR, and bad survival, low TAPSE with significant TR. So now let's actually think a little bit outside the box, outside of the guidelines, which is my favorite thing to do in this condition, and give you some examples of where thinking along physiologic lines can actually debunk long-standing practice patterns and actually show that things need to be questioned and may actually even be wrong. And so, you know, a time-honored teaching in congenital heart disease, namely in patients with a systemic to pulmonary shunt, is that if a patient has significant pulmonary hypertension, that the defect cannot be closed. And this is just a case series of patients that had atrial level shunts. I think half were secundum and half were a sinus venosus with anomalous pulmonary veins, where we used what we called a treat and close approach. By the way, this paper was published in 2020. That is a little bit misleading because it took us like 3 years to publish this paper because it was rejected by like 5 or 6 different journals before we got it finally published. So it can tell you what the medical community, there was a lot of resistance to this. And so this was a group of patients that had, if you look all the way to the left column here, pulmonary pressure is 86 over 29, 125 over 55, 97 over 29. Baseline PVRs of 5, one was 8. And the baseline QPQS ratio here, 1.7, 1.4, 1.5, 1.7, very typical actually of systemic to pulmonary shunt in the presence of a high PVR. Important to note, these patients did not have Eisenmeinger's, right? It's not especially common for a patient with an atrial level shunt to develop Eisenmeinger's at all. But nevertheless, it's important to make the distinction. These were systemic pulmonary shunt patients with PAH, but not with Eisenmeinger's. And these patients were treated with a variety of different PH medical therapies and then recast and echoed over time. You can see their follow-up PVRs dropped significantly by half or more in most cases. Very importantly, the QPQS ratio predictably went up 1.7 to 2.1, 1.4 to 2.5, 1.5 to 3.6, 1.7 to 2.6. And the follow-up PVR to SVR ratios were a third or less. We did close these defects. These were all surgical closures, by the way. And all of the, this was just at the time of the paper showing you follow up at 36 months, but walk distances going up, BNP levels normalizing. All of the patients in this series are still alive. The one woman in the case series has gone on to have 2 children. And so I think that, and I've done this subsequent to this paper in other patients as well. And so we just have to be careful when we say, oh, the patient has PH, their defect can never be closed, because it depends on, how you are approaching the treatment of that patient. We've had a significant experience with management of PAH in pregnancy. We published a case series a few years ago showing our experience at Temple We actually had a number of patients at Penn as well, but I could not actually access those records for this case series. But the whole idea in PAH and pregnancy is that, first of all, pregnancy does occur in patients with PAH, and no, not everyone is going to terminate their pregnancy. And so I learned early in my career that whether I liked it or not, I was going to have to manage pregnant women with PAH. And so we've titrated medical therapies really to develop a sufficient cardiopulmonary reserve to withstand the physiologic stress of third trimester hemodynamics, active labor, and postpartum following placental delivery. And the PAH patients, their ages 32, anywhere between 24 and 32 or 32. Patient 1 was the patient who delivered twice. She was secundum ASD post-closure, idiopathic PAH in the next 3. Patient 5 actually had an unrestricted VSD with Eisenmeinger's, and patient 6 was a lupus-associated PAH. Patient number, was it 2 or 3? Actually was twins, was di twins. And she was already on Remodulin when we met her. Patient 2 is di twins. The delivery indication and mode, vaginal delivery in patients 1 and 3, and C-section for patients 2, 4, 5, and 6, importantly, all by obstetric indication, meaning these are not empiric C-sections. This was for preeclampsia or a prior C-section, very important. Epidural anesthesia in everyone. And what's important is that all the patients were treated with medicines like PD-5 inhibitors and some form of prostacyclin. We cannot use endothelin receptor antagonists. We cannot use soluble guanylate cyclase stimulators like riociguat in pregnancy because of teratogenicity. And all of the patients were treated to either mild RV dysfunction or less, normal jugular venous pressure and normal BNP values. And very importantly, all of the patients and babies survived, high APGAR scores, all moms, all offspring alive and well to this day, no ECMO use. And it was predominantly on the basis of treating to a physiologic target, which was normal or near normal RV function, a normal right atrial pressure, and normal BNP level. This was a fun one. This was a case series we published a number of years ago on patients with end-stage renal disease that were incredibly short of breath, that were shown to have a reversible cause of dyspnea, heart failure, and PH related to arteriovenous dialysis access. There's only really one main thing I wanted to point out to you in this paper, is that the average cardiac output at baseline in these patients was 10 liters per minute with a cardiac index of about 5. But please take note that when we did acute manual fistula occlusion in the cath lab, on average, the cardiac output dropped from 10 liters a minute to about 9 liters a minute. So there's on average about a 1 liter acute reduction in cardiac output with manual fistula occlusion. But when we recath the patients 3 months after their fistula was surgically closed, look at the difference between resting cardiac output of 10 liters a minute and resting cardiac output a little under 6 liters per minute. So an acute decrement of 1 liter per minute acutely with manual fistula occlusion translated to a 4 liter drop in resting cardiac output after the shunt was definitively closed. I'm more than happy to take questions on that at the end if people would like to discuss that. These patients dramatically improved walk distance, functional class, BNP, hemodynamics, RV size and function, everything. We'll shift a little bit to pulmonary hypertension and lung disease. This has been an area of very active investigation and over a number of years. It's also a controversial area in that there's been some incredibly poorly designed clinical trials in this space over the last 20 years that have really confused the literature, that have led to a significant delay into finally the approval of one particular agent, inhaled treprostinil, to treat pulmonary hypertension in patients with fibrotic lung disease. But that study was long overdue and delayed by a series of very poorly designed studies that would never have worked and were almost designed to fail from the beginning. So applying the PH syndrome outside of group 1, well, non-group 1 disease requires an even greater understanding of physiologic concepts than in something like group 1 disease. This is actually the INCREASE study. This was the New England Journal paper in 2021 that said that inhaled treprostinil to treat pulmonary hypertension in ILD actually was effective, quality of life, 6-minute walk, etc. But what's very important to understand is that only the patients whose baseline PVR was more than 4 derived benefit, and the average PVR in that group was a little over 7, okay? So who benefited in PH-ILD? Patients with an average PVR of 7. Why is that? Because this is actually a real pulmonary hypertension syndrome. When your PVR is up, your RV function is down. There's a circulatory limitation to exertion embedded or superimposed on a background of fibrotic lung disease. That gives you a pulmonary hypertension process to address. It is a physiologically meaningful baseline level of pH. Still to this day, people are scratching their head as to why inhaled treprostinil worked. In the INCREASE study, it's an inhaled therapy. Inhaled therapies go into the lungs. Treating the lungs and lung disease is good. It prevents VQ mismatch. This is all hand waving. It's actually not what the data showed. What the data really either showed or implied was that if you had a clinically meaningful physiologic process of pH with a high PVR and RV dysfunction, that it is the alleviation of that cardiovascular process in the background of their lung disease that is the target for therapy. What's interesting is that there was a paper a number of years before that actually showed that sildenafil preserved exercise capacity in patients with IPF and right heart dysfunction. In fact, what it showed was that it was only the patients with RV dysfunction that derived benefit in this study. If you had IPF and your RV function was normal, you did not derive benefit. In fact, the 6-minute walk tended to go down. But if you did have RV dysfunction at baseline and you were treated with sildenafil, not an inhaled therapy, actually there was a trend or actually a statistically significant increase in the 6-minute walk distance. We actually published a paper several years before the New England Journal paper using parenteral treprostinil. So this was IV and sub-Q Remodulin in patients with pulmonary fibrosis. And again, this was considered sacrilege. You cannot give a parenteral therapy to a patient with parenchymal lung disease because they're going to become more hypoxic, right? But that's actually not what happened, okay? What we did is we enrolled a group of patients that had a real PH syndrome, PH, a high PVR, RV dysfunction, and a clinical presentation that matched that. And actually, the patient did very well in that context. Their walk distance went up. Their hypoxia at rest or with exertion did not change. Their lung function did not change. Their hemodynamics improved. Their BNP levels fell. And their quality of life scores all substantially improved. We had published a paper in 2013, which was more of an invited review, where we were asked to write on pulmonary hypertension and lung disease, which we entitled Pulmonary Heart Disease, the heart-lung interaction and its impact on patient phenotypes, where we said, look, let's take patients with group 3 PH and let's create 2 different physiologic subtypes, a type 1 and a type 2. Type 1 is going to be your patients where lung disease is the predominant condition. The PVR is not that high and the RV function is normal. Okay. And pulmonary heart disease type 2 is going to be where the PVR is elevated, the RV is dysfunctional, and the degree of circulatory disease burden is far higher, which means the circulatory reserve is lower. What we hypothesized in this paper, in this review, is that if you considered patients along these physiologic subtypes, it would actually create enrollment criteria for future clinical studies where patients would derive benefit from PH medical therapies in lung disease. And so the concept I like to summarize in this slide, where if you look at the degree of RVPA uncoupling on the y-axis, whether it's mild, moderate, or severe, and then the degree of source organ dysfunction on the top of the panel moving from left to right, too early, best chance, too late, what we find is that this is where you're going to be in your sweet spot, is when patients have a meaningful degree of pulmonary hypertension syndrome, but their lung disease is not yet at an end stage, right? If a person has end stage pulmonary fibrosis and they're on 10 liters of oxygen around the clock, saturating in the high 80s, the gas exchange function of the lung is so diseased and impaired, and there's so much architectural distortion of the lung parenchyma that intervening on pH probably is not going to make a difference at all. But that's just because the organ itself is at an end stage. And in the last few minutes, I'm going to transition to thromboembolic disease and just talk about our experience with that. And it's very relevant, of course, to Emory. This was the first paper that Ken Moser published when he was still at Georgetown. Ken Moser then went on to go to UC San Diego and start the CTEPH program in UC San Diego, and the rest is history there. But this was the removal of what they described as a fibrothrombotic cast from the right main pulmonary artery. And it showed that this was possible to do, and this patient improved dramatically. This was our first PTE specimen from Temple in June of 2013. And so I'm just going to talk about how we build the CTEPH program just by general principles and impress upon you that we're going to do the same thing at Emory, and we already have. So it starts with interest, or as Simon Sinek said in his book, you start with why. You actually have to care. You have to be super interested in the disease. My mission statement in Philly was to bring world-class CTEPH care to patients in Philadelphia and the East Coast, and now it's to do it in the South, and then nationally and internationally. You build a program, a legitimate foundation of PH and CTEPH expertise, which by way of analogy means you should have your black belt in pulmonary hypertension before you try to build a CTEPH program. This is not a starter type situation. You really have to know what you're doing in PH first. There has to be a deep commitment to learning, teamwork, and you must minimize mistakes in patient selection, in surgical technique and approach, and in ICU and postoperative management. What you don't do to build a CTEPH program, very common across the country, I've seen it for years now, is fake it till you make it. Excess focus on websites, excess reliance on glossy marketing materials, Twitter and other things, social media, to try to convince the general public and referring physicians that you know what you're doing. You actually do that by knowing what you're doing, one patient at a time, and it organically will grow. CTEPH has a lot of potential mines in the minefield here. If you make poor patient selection, if you have an incomplete PTE surgical technique or vessel injury during the surgery, or you have poor post-PTE management, or your ambition exceeds your skill, those is where you're going to expose these landmines in the minefield. Your program will do very poorly. It'll translate into poor patient outcomes. So you have to be super careful with your patient selection. You have to have a highly skilled surgeon. You must have meticulous post-operative ICU management. and follow-up care and what I call mistake-free medicine, which doesn't mean we never make mistakes, but it does mean that our goal is to not make any mistakes in every single patient interaction. How do we maintain a CTEP program? We keep and build on our core values: interest, expertise, learning, teamwork. Like I said, minimizing mistakes. We communicate with referring docs. We make them part of the team. We stay humble, and we don't forget where we came from. This is an empty lot in North Philadelphia. This is essentially analogous to the program or lack thereof in Philadelphia when I came there in June of 2013. I definitely did not leave it that way when I left in July. That's just showing our referral pattern throughout the United States at the time that I left. By the way, Georgia and Florida were our number 2 outside the region referral areas, which I strongly believe will translate into referrals into Emory, and it already has. And I found that actually this is a picture I found on the internet of 1,000 people in a room. And so this is 1,000 people that have had interventions at Temple for CTEP, over 500 PT surgeries and over 500 balloon pulmonary angioplasties. And I think that the possibilities at Emory are honestly even greater. And so I summarize to say that pulmonary hypertension is a broader field than often recognized, that PH expertise has a ripple effect in the health system. It can unlock high-end services. I would welcome people to consider PH as a syndrome, applying physiologic principles over diagnostic categories. This allows you to think outside guidelines in more difficult cases to solve difficult situations for patients. Non-group 1 disease requires even greater knowledge of PH than group 1. And then CTEP is a specialty unto itself, rewarding, humbling, competitive, and so buckle up. And then I pretty much always end my talks with a picture of Ron Burgundy, who is my hero, and the Action 4 news team on the right. So I'll stop there. Thank you very much.
Thank you, Paul, for an excellent talk and reviewing with us physiology and hemodynamics of pulmonary hypertension this morning. In the interest of time, it is right at 8:30. We're going to take a few questions. If people want to type their questions in the chat. I'm going to go ahead and ask a question. So for general cardiologists, when we see, from what I understand, I want to hear your thoughts about this mild RV to PA coupling problem and relationship to symptoms, because we see a lot of patients with dyspnea and dyspnea on exertion. And, we've looked for stress tests, we've looked for left heart cath, all of that is fine. Let's say no obstructive disease, and you see mild PA pressures that are elevated. What do you do in your practice? Do you recommend that we do exercise, cardiopulmonary exercise testing because of your interest in exercise physiology, and then refer for evaluation for pulmonary hypertension if it's early?
That's a great question. So as you're indicating, this comes up all the time, right? And in fact, my interest in the invasive cardiopulmonary exercise test and exercise testing in general actually came from, in part, those clinical scenarios themselves, right? But I'll start by saying that clinically, one of the easiest and most reliable ways to discern whether pulmonary hypertension is the cause of someone's dyspnea is to cross-reference or contextualize the patient's functional impairment against what their RV size and function are, okay? And so if someone tells you that they're short of breath walking across a room and they have normal RV size and function at baseline, the chances that pulmonary hypertension explains that level of functional impairment is essentially zero, right? The person is giving you a 1 MET exercise capacity of impairment, but their RV size and function are at baseline are normal. That is going to largely exclude a real pH processes explaining their impairment. But if someone has a higher level functional impairment with RV function that's maybe mildly impaired, then that may require a greater level of inquiry. But the great thing about cardiopulmonary exercise testing is that it will objectify whether someone has a cardiac limitation, a ventilatory pulmonary limitation, both or neither. And there are gas exchange signatures of pulmonary vascular disease on a CPET that are easily discerned by a skilled reader. And so any of these questions come up, this is like really one of the most fundamental kind of services that a PH practice provides when I think doing it right, because you can always exercise the patient to kind of settle that question.
Mm-hmm. Okay, great, thank you. Mahmoud has a question.
Yeah, thanks, Pooja. Paul, thank you very much. This was absolutely fascinating and amazing. You know, I've through the years, I've heard your talks multiple times, and very fortunate to have you just across the hallway. I can come and knock on your door for questions. Actually, my question is a follow-up from Pooja's comment, and it's mainly comes into the spectrum of this pulmonary or exercise-induced pulmonary hypertension, and where it falls in the spectrum of heart failure with reserved EF. And if we believe in the theory that I think physiologically makes sense, that HFpEF starts with exercise-induced pulmonary hypertension, goes into the real deal HFpEF on exertion or dyspnea on exertion, and then ends up with full-blown pulmonary hypertension and RV failure. I always struggle with that and with what we can do. And usually these referrals from our general cardiology colleagues, I put them on the on the cath lab table and have them do a recumbent bike and really demonstrate that their pulmonary pressures go up with exercise. The question remains is what to do with these. It's a lot of nuances. Of course, it's always patient to patient selection and individualized care. However, I want to hear your thoughts about that and in the realm of SGLT2 inhibitors and any other ideas you had.
This is exactly the scenario where you have to go back to your physiologic principles, right? And so mean pulmonary pressure is cardiac output multiplied by PVR plus left atrial pressure, right? And so an elevated pulmonary pressure with exertion can mean that it's any of those three parameters alone or in combination that's explaining the pressurization of the pulmonary circulation during exercise, right? So the question is, where is it coming from? And if the pressurization of the pulmonary circulation is only occurring through the interaction between a rising cardiac output and a rising left atrial pressure, although we call that exercise and pulmonary hypertension, what it really is exercise-induced left heart congestion. And the pulmonary circulation is an unrestrained parameter that is not holding the right heart back at all. And so therefore, the pulmonary circulation is not the source of the disease, right? And so when we see wedge pressure to cardiac output ratios that are 3 or more, a PVR that is falling with exertion, it starts at 2, it ends at 0.7, recruitable stroke volume, and a disproportionate increase in left atrial pressure to right atrial pressure. These are characteristics of systemic arterial disease, left heart disease, where the increase in pulmonary pressure is the byproduct of those factors, but not of a diseased pulmonary vascular bed. And so the only things you really can do are try to modify the conditions that are existent in the systemic circulation, the left heart, loading conditions, et cetera, right? So, and I strongly believe that in the HFpEF world and in this kind of exercise-induced HFpEF scenario, that GLP-1 is going to maintain an enormous role in the modification of this process over time, because I strongly believe that adiposity, insulin resistance, and salt and water retention, vascular stiffening of the systemic circulation are so heavily impacted by the obesity process. And we've seen complete reversal of HFpEF and refractory HFpEF patients through adipose tissue weight loss. And so, yes, the SGLT2 inhibitors already are showing a huge amount of promise in HFpEF, but I think that the proportion of HFpEF patients that are obese and morbidly obese is huge. And I think that this is an area that we do need to focus on in these pure passive congestion type of scenarios. That's one part of an answer to your question. So you always want to pay attention to where physiologically the origin of the pH is coming from during exercise. And we can do all of those calculations during an invasive CPET to show people where the pH is coming from.
Okay, thank you, Paul. Thank you so much. In the interest of time, we're going to close if nobody else has any questions. Thank you again for a wonderful talk, and we're very glad that you're here at Emory, and we'll be sending you patients for sure. And thank you, everyone. Don't forget to get your CME, and I will see everyone next week.
The preceding program is copyrighted by Emory University.